I welcome all the delegates, faculty, moderators, panelists for this international webinar series. I am Dr. T.S. Chandrasekhar, ACG Governor, India region, and I will bring warm greetings from the World Gastroenterology Organization as a member scientific committee. I represent the Tamil Nadu Dr. MGR Medical University as the honorary visiting professor, and I am holding the post of founder, chair, chief gastroenterologist, Med India Hospitals and Academy, Chennai. I once again welcome to this international webinar. Our previous two webinars saw the participation of over 9,000 delegates from all over the world. That really inspired us to do further. This medium is going to be of great use to the rest of us, and that really inspired us to go for the international webinar series 3 on gastroenterology. This time we gave a tag, name the topic the world experts are here. It created a news because the new Endo-GE webinar series. And it has been accredited by Tamil Nadu Dr. MGR Medical University 1 credit hours and endorsed by the American College of Gastroenterology. It is an initiative of the Med India Hospitals and Academy. The first series, we actually organized, scheduled 12 webinars in this calendar year from April 24 to March 25. And the first series of lecture was inaugurated by none other than Professor Dr. Jonathan Lyton, who is the president of American College of Gastroenterology. And the last webinar was held in September. We saw the participation of one of the great stalwarts in the field of gastroenterology, Nobel laureate, Professor Dr. Barry Marshall. And he is a discoverer, I should know that, discoverer of Helicobacter pylori. We had several thousand delegates attended this webinar from all over the world. And this webinar would not have been possible without the cooperation from my colleague, Dr. Gokul, Satya, Rajayogesh, and Dr. Prasad, and Dr. TNS. And what we designed this webinar is, India is a huge country. Every state is being represented by my colleagues who are the honorary ambassadors for this webinar. Dr. Chaubal, Dr. Pradeep Roy, Ramesh Kumar from Telangana, Srinivasa Rao from Andhra Pradesh, and Praveen Kumar from Kerala, Arvind Gopi from Karnataka, Greece from Odisha, Mahapatra from West Bengal, and Nirmal Jeet from Punjab, and Rajiv from Maharashtra, and Lamba from New Delhi. What they have decided, they carry the message of this webinar to their colleagues at a huge country. And we are also very thankful for the international webinars from USA, Malaysia, Nepal, Bangladesh, Nigeria, UAE, Australia, Nigeria, Sri Lanka, and Nepal. And the two latest additions is Dr. Evaristus from Nigeria and Bhamanta from Sri Lanka. I am very thankful. And our next webinar will be on hepatology, and Dr. Shusarin and Dr. Ajay will be talking. And after that, we have Dr. Douglas Rex and Nageshwar Reddy. Then we have Neil Stolman talking on fecal microbiota, and Dr. Ramakrishna talking on probiotic and high colonoscopy quality indicators by Dr. Costa Stefalis, and H. pylori by William. See, you just saw the editorial in American College of Gastroenterology on H. pylori, and we have some GA malignancy, non-adenomatous cancer. And all these webinars have been accredited by Tamil Nadu Medical Council. Even those coming from other than Tamil Nadu state also can claim, provided they get the letter and the council, Tamil Nadu Medical Council accreditation certificate. Now this webinar would not have been possible without the help from Micro Labs Limited, and they have been the Micro Knowledge Academy has been our academic partner. And coming to today's webinar, we have two interesting topics, Barrett's esophagus. For most of the Indian gastroenterologists may look, are we seeing Barrett's esophagus or are we missing a Barrett esophagus, or we are not using the latest technology to diagnose Barrett esophagus, or genetic kind of protection the Indians and they getting it so that we don't see the Barrett esophagus. All these things will be answered in this webinar. And 1/3 of our practice volume is on from good, established and latest facts we are going to have that. And my duty is to introduce the panel and the faculty introduction. Professor Nicholas Sahin is the Secretary General of American College of Gastroenterology, and he is Muslim. I don't know whether I spell it rightly, and please pardon me if I don't spell it rightly. Muslim T. Heiser, Distinct Professor and Chief, Department of Medicine, Gastroenterology, University of North Carolina School of Medicine, USA. His areas of interest, very interesting. Precancerous and cancerous, and for his groundbreaking research on Barrett esophagus, he is best known for that. And he is a recipient of Master Endoscopist Award from American Society of GI Endoscopy. Now I want to introduce Professor Sandeep Laktakia. He is our colleague and he is the Director of Endoscopy and US, Asian Institute of Gastroenterology, Hyderabad. He is our past President, Society of GI Endoscopy of India. He is in various committees, one of the important committee, steering committee member of Asian US group. He has got publication to the tune of 170. He is a visiting professor in one of the prestigious universities in Myanmar. I welcome you both, Professor Nicholas and Professor Sandeep. The another speaker is Professor Sobna Bhatia. He is a senior consultant gastroenterologist right now in Mumbai. He is a member of Functional Esophageal Disorders of Rome 5 Committee since 2021. His publication has been over 140 and editor emeritus. This is a very important thing. Indian Journal of Gastroenterology, and he has authored book chapters on esophageal motility, GI reflux, and the irritable bowel syndrome. He is a recipient of Unicum Lectureship in Gastroenterology. Another moderator is Professor Dr. Amit Datta. He is a professor of gastroenterology, CMC Vellore. He is the editorial board member of World Gastroenterology Journal, and his H index is over 24. He is a recipient of Om Prakash Memorial Award, Indian Society of Gastroenterology. And very important thing is special interest in advanced endoscopic imaging, which is the current important thing to diagnose early cancer and luminal GI disorders also. And we have learned panelists, expert panelists, my colleagues, Dr. Venkatakrishnan. He is the head Department of Gastroenterology, PhD from Medical Sciences, Coimbatore, South India. And Dr. Vikas Singla. He is another eminent in the International Gastroenterology, and he is heading the division Max Healthcare, New Delhi. And Professor S.P. Mishra, known for his academic activity, tremendous publication. He has been the president of Indian Society of Gastroenterology, and he is a very critical reviewer of most of the article. I've enjoyed listening to him. And Dr. Barnama Duraraj is the Professor of Gastroenterology, retired from Madras Medical College. Right now he is working in St. Isabel Hospital in Chennai, India. Now, with this introduction of our faculty, why the topics are so important, how we are going to deal with this topic, how our practice can improve after listening to this lecture is going to be the main thing. I once again welcome the delegates from all over the world and our faculty for this. Now the lecture session starts now. I welcome Dr. Sandeep Laktakia to invite our first speaker, Professor Nicholas, and start the proceeding.
Thank you, Dr. Chandrasekhar. I think we had a long, introductory messages. I think we'll straight away move to Professor Shaheen for his talk on Barrett's esophagus. I think let's start. Nicholas, over to you.
Wonderful. Thank you very much for having me, and I hope that you find this useful. Perhaps I can share my screen now and please inform me if you're able to see my slides.
For the audience, Dr. Nicholas Shaheen is a pioneer in several studies in Barrett's esophagus, including the landmark trial in NEJM. We'll be listening to him and understanding how Barrett's is managed, diagnosed, and where are we missing our Barrett's if they are there in India.
Sorry for the delay, and again, thank you for inviting me. It's a pleasure to be here today. For the next few minutes, I'm going to discuss with you Barrett's esophagus, which is an area that I think you will have increasing reason, unfortunately, to worry about in India if I had to guess, and I'll tell you why I think that is the case. Here are my disclosures. I get research grants from multiple corporations and am a consultant for several others. As many of you know, Barrett's esophagus used to be a disease primarily reported in Europe and the Western Hemisphere. But then this happened, and this is a picture of a Kentucky Fried Chicken stand in Tokyo, one of the first on that side of the world, and now unfortunately both eating habits as well as trends in obesity in Asia are starting to follow Western trends, and because we think obesity is a main driver of what we're seeing with Barrett's esophagus, I have reason to suspect that you will have increased interest in this disease state. Increasing obesity is seen certainly in India, and I don't need to tell you this, but here's a recent map of India showing what the prevalence of obesity is by region, and you can see that there are regions of India that have greater than 50% obesity now, similar to some places in the U.S. And the question, of course, becomes, will esophageal cancer trends in Asia recapitulate those in the West? As obesity goes increasing in prevalence, will you see these same trends? And these are trends, what you see here are 4 different lines. And what these lines represent is the epidemiology, the incidence of squamous cell carcinoma of the esophagus in men and women in the West. And what you can see is this is squamous cell cancer in men in the West, and it's had actually quite a decrease over time from the 1980s to present. On the other hand, this is esophageal adenocarcinoma in the West, and you can see that we've seen a 500% increase in this cancer over that same period of time, okay? Here are the corresponding bars for women. You can see that for both squamous cell carcinoma and esophageal adenocarcinoma, the incidence is lower in women than in men, but the trends hold. You can see that for women, this yellow line in squamous cell cancer, their risks are going down over time. Women's esophageal adenocarcinoma risk is increasing, albeit not quite as impressively as in men. However, interestingly, it doesn't seem to be that there has been much change, although you're seeing recapitulation of the obesity trends in India, at least as of now. Here's some recent data from India looking at trends in cancer, and I'll call your attention to this panel here, which is esophageal cancer. You can see that there are several regions represented here, and if anything, the overall trends in esophageal cancer seem to be going down somewhat. The other thing that I'll point out to you, which I think is quite interesting, is that the risk of GI cancer varies dramatically in India depending on where you live. And here's some interesting data kind of broken out by region of the country, and then you can see the various states, etc. You have remarkably different epidemiology of gastrointestinal cancer in India depending on where in India you are. And this, I'd be interested to hear folks that are living with this every day, what your thoughts are regarding this heterogeneity, because I found that quite striking as I looked over these data. It's certainly not because you don't have reflux. So we think that Barrett's esophagus occurs because patients have chronic reflux disease. They get a metaplastic change from the squamous epithelium, which is not very resistant to damage from reflux, to the intestinal metaplasia, which is much more resistant to damage from reflux. When you look at, these are some relatively recent data, epidemiologic data on GERD, and we may hear some more about this in the second lecture of today, you can see that some of the highest reported symptom burden of GERD in the world is actually in India. And it's higher than that generally reported in the United States or Canada. So I don't think that the reason that you're not seeing as much Barrett's is that you don't have as much reflux, because the data don't support that idea. One thing that does occur to me is that it takes decades to recapitulate the process that we've seen in the West. By that I mean obesity rates started going up in the 1950s. We didn't really see this dramatic rise in our cancer incidence and our cancer mortality. These are cancer incidence and mortality curves really until the 1970s, which leaves us with the unsettling prospect that perhaps it's a time lag phenomenon and that you eventually will see Barrett's esophagus and an increase in adenocarcinoma, and it just hasn't happened yet, okay? When we look for genetic predisposition of disease, we find some relatively weak predisposition genes for Barrett's and esophageal adenocarcinoma, but I doubt that there's an enormous genetic predisposition to this cancer that's strikingly different between India and the United States. Time will tell, and there's research being done in this area. One thing I can tell you for sure is that in the West, we're failing our patients in the battle against esophageal adenocarcinoma. We've been relatively ineffective in stopping this rate of increase. And the reason for that is that most presentation of esophageal adenocarcinoma is late stage. And what you see here is, this is a single center study, but all of them look the same. What T-stage esophageal adenocarcinoma presents. So I'll remind you that T1 disease is very early stage disease. T3 and 4 disease are late stage disease. At this point, treatment options are few and the prognosis is grim. And what you can see is that the vast majority of cases are presenting with T3 and T4 disease, almost 90%. And as you can imagine, we're not making much headway with these cancers. This is Barrett's esophagus through the endoscope. I'm sure many of you have seen this. We do see a lot of this in the West compared to India. But the normal squamous epithelium is here in the foreground in these two pictures. The salmon-colored mucosa that's radiating upwards here is the metaplastic epithelium, the Barrett's esophagus. We care about it because it's the only known histologic precursor to adenocarcinoma of the esophagus. I really like this picture here on the upper left. This is non-dysplastic Barrett's esophagus. You'll see a little tongue of the normal squamous epithelium here on the right of this slide. And then if you look over here, you see clearly a glandular epithelium. However, the crypts are very nicely formed. The nuclei are basally oriented and look very orderly. This is non-dysplastic Barrett's esophagus. This can progress to low-grade dysplasia. Now you're starting to see bigger nuclei. You still have polarity by and large. You still got glandular structure. That can move on to high-grade dysplasia. Now you see quite a bit of nuclear enlargement. You're starting to get some effacement of the normal glandular structure. And that can, of course, go on to adenocarcinoma of the esophagus, as you can see in this picture here. Now, I presented this like this is an inexorable progression. However, in reality, the vast majority of patients will stay in these two grades of dysplasia, and it's relatively rare, with well less than 10% of the population progressing to high-grade dysplasia or cancer. Now, I've already shown you that this cancer has increased dramatically in the West in the last 4 decades. Now, if Barrett's is the precursor of this cancer, then we should see an increase in the epidemiology of Barrett's as well. And sure enough, when you look for it in Western reports, you will find that almost inevitably you see an increase in detection in Barrett's esophagus as well. Here's one nice study of about 60,000 endoscopies in Spain, and you can see that the proportion of endoscopies that show Barrett's, both short segment and long segment, so the black line represents long segment Barrett's esophagus of 3 centimeters or more. The gray line represents short segment Barrett's esophagus. This is less than 3 centimeters. And you can see that they've both gone up dramatically. Now, some of the increase in short segment Barrett's esophagus may just be detection bias because of better endoscopes and what have you. But suffice it to say that certainly this represents a real trend. The trends in India and Barrett's are not as clear. Some studies suggest that the prevalence is likely low and that most disease is short segment Barrett's of less than 3 centimeters. However, these are single center or pathology studies. In one study of 127 patients that I've listed, or 271 patients which I've listed down here, undergoing EGD, that suggests that the prevalence of short segments of intestinal metaplasia might be as high as 6%, which is actually quite high. And that the presence of short segments of intestinal metaplasia were associated in this study with age, the presence of esophagitis, but interestingly not associated with GERD symptoms or hiatal hernia. It's unclear from these studies if associations noted in Western studies hold up in the Indian population in terms of obesity, GERD symptoms. As you know, in the West, obesity and GERD are strong predictors of both Barrett's esophagus and esophageal adenocarcinoma. Given that over 80% of the esophageal cancer that occurs in India currently is squamous cell cancer, it's likely that Barrett's esophagus is not yet a major source of cancer cases in India. And I'll stress this "yet" idea because I do wonder about the possibility that this is something you will be seeing. So why do we see this impressive increase in esophageal cancer in the West? I've alluded to this already. No one knows for sure, but some postulate that the increasing cancer incidence could be secondary to the epidemic of obesity. And sure enough, when you look at obesity as a risk factor for adenocarcinoma of the esophagus, this is a nice study from Jesper Lagergren that was in Annals of Internal Medicine. What you find is that when you compare low body weight individuals to even those of average body weight, there's about 4 times the chance of getting this cancer. Amongst the overweight, that cancer goes up to 8 times the risk. And if you're obese, you have about 16 times the risk of getting this cancer compared to a low-weight individual. You may have seen these maps before. I find these maps fascinating. This is the proportion of obesity by U.S. state. And similar, I've already shown you an analogous map for India, but you can see here that we have very similar and very worrisome rates of obesity in the United States, and the colors indicate the proportion of the population which is obese. And you can see with that, with the exception for a few outliers here, like District of Columbia, Colorado, and California, the vast majority of the states, especially those in the Midwest and the South of this country, I live here in North Carolina, have at least 30% obesity, and some of these states are getting up to 50% obesity as well. So what are we doing to try to prevent this cancer? And I think that there are some illustrative stories here that can help you when you think about this in India as well. Right now, endoscopists are trying to lower the risk of cancer death in those with chronic reflux by performing screening and surveillance endoscopy. We scope those with chronic heartburn, which is one of the biggest risk factors for the presence of Barrett's. That's called the screening exam. And then we periodically rescope those with Barrett's to make sure that the Barrett's does not progress through the dysplasia, and that's called the surveillance exam. And regardless of the society you look at in the West, we all have some variant of these kind of guidelines for Barrett's screening. And you can see I've listed the various societies here. This is the American College of Gastroenterology. This is the European Society for Gastrointestinal Endoscopy, the American Society for Gastrointestinal Endoscopy, the British Society of Gastroenterology, and the AGA. They all have the same idea. If you have multiple of these risk factors, then you should have a screening exam. The problem is that GERD symptom presence and frequency are poor predictors of the presence of Barrett's. In other words, GERD does not predict the presence of Barrett's as well as we would like it to. And in fact, multiple studies have looked at this, and in series after series of esophageal adenocarcinoma, you find that somewhere between 20 and 51% of the patients have no or infrequent reflux symptoms. So if we're using reflux symptoms as our entry criteria for screening, we already lose about 40% of the cancers because they never get into the screening pool. So the upshot of this, and if there's anything you remember about this and kind of mull over this as you think about how to handle these issues in India, is that we're not getting to the people we need. Here are two studies that are pre-ablation era studies that ask the simple question: among the patients who developed cancer, how many of them knew they had Barrett's before they got their cancer? Because you're not going to prevent the cancer if the patients never knew they had Barrett's in the first place. And what you find, I show you two here, but there are multiple studies, they all have the same finding, is that greater than 90% of the patients who developed this cancer never knew they had Barrett's in the first place. So by concentrating on Barrett's, we're missing the yellow piece of the pie. We're only allowing ourselves the chance for intervention in Barrett's, which is the white piece of the pie. And when you think about this, it really puts in context what I'm about to show you about endoscopic interventions for Barrett's, because we do very well now keeping the white piece of this pie from ever going on to getting cancer, but we're not doing much for the yellow pie, which, by the way, I don't think has changed much in the 20 years since these pre-ablation studies were done. So this is what's currently happening in the U.S., and this is a nice model that Tom Vaughn and Rebecca Fitzgerald did, asking the question about how is it really working, how's our screening really working in the United States? And when they did this model, there were about 150 million people in the U.S. who are over the age of 40. We know from the epidemiology of reflux in the U.S. that about 20% of people have daily to weekly symptoms of GERD, and about 80% of people do not. And we also know that we're concentrating on this 20% of people with GERD. So in that 80% of people who are not having GERD, I've already told you that 40% of the cancers occur in people without GERD. So we've already lost those 40% of those cancers in terms of preventing cancer. 60% of those cancers are going to happen in the 20% of people with GERD, so GERD is a good stratifying risk factor for cancer. However, we know, at least in the U.S., that 90% of those patients, 90% of that 20%, will never get endoscopy. If you assume that the cancers, the 60% of cancers are evenly spread throughout this 30 million people, we're going to lose another 52% of the cancers. And you can see where we're headed here. Between the 40% we lost because they didn't have GERD and the 52% that we lost because they never got endoscopy, we've already missed the vast majority of the cancers, and we've missed our chance to prevent those cancers. Now, amongst that small percentage, the 10% or so that does go on to get endoscopy, we assume that most of them will be diagnosed with Barrett's. However, we'll miss Barrett's in a small percentage, perhaps in 1/8 of them. So the short answer here is that of the 10,000 cancers that were going to occur in that year, it's higher now, only about 7% were identified through current approaches to cancer control. So when you think about it this way, you can see why we're not making much headway with this cancer. So we've got to find a better way to detect at-risk patients. And that brings the question up, is there a better way to screen patients who have heartburn for Barrett's esophagus? And I'll show you a couple things we're working on now. The first one I'll show you here is a device called Cytosponge, which was developed by Rebecca Fitzgerald, who's a brilliant woman at Cambridge in England. This is a low-tech sponge in a capsule that you swallow and drink, and then it sits in your stomach, and the capsule eventually dissolves, the sponge springs loose, and then after 7 minutes you retract this, and it samples the distal esophagus. By the way, it samples throughout the esophagus, and people are looking at this as to help detect squamous cell carcinoma as well. You pull it out, you extract the cells from the sponge, and you stain it for trefoil factor 3, which is a sensitive marker for intestinal metaplasia. And this is what you get. This was a study of about 500 patients who were screened in this way in the general medicine clinic. And you can see for Barrett's esophagus, for small amounts of Barrett's esophagus, sensitivity was okay, specificity was pretty good. If you have at least 2 centimeters of Barrett's, i.e. a longer segment, those numbers get up there, 90% sensitivity and 94% specificity. I'll show you another one that we're working on. It's the same idea, but it's a little bit more selective. The way that this works is that it's a balloon that's inserted in the deflated form. You'll see it'll retract inside this hood. You swallow it that way. After you swallow it, we blow it up, the balloon in your stomach, and then we pull it through. We deflate it in the mid-esophagus, and then we bring that out and we cut that little balloon off at the end. And again, this time we extract DNA and we check it for methylation markers. That's called ESA-check, and this is the first study we reported it in. And you can see, if you're used to looking at AUC curves, these are AUC curves for 2 methylation markers, CCNA and methylated vimentin. And the panels on the right are for cancer, on the left for Barrett's esophagus. And you can see that the areas under the curve for all of these look quite good, about 0.95, that these methylation markers are quite good at detecting both Barrett's and esophageal cancer. And this is a big data table, but I'll call your attention to 2 numbers here. Amongst those with and without disease, the idea that either one of these 2 markers would be positive shows great sensitivity. It's actually quite impressive how sensitive this test is. And that was developed by these 3 folks here who are at Case Western University, Sandy Markowitz, Amitabh Chak, and Joe Willis. So now we're doing these kind of non-endoscopic screening studies to see if we can increase the number of folks that are screened in the West in large unselected primary care populations. Also, remember I told you already that we lose 40% of the cases because they don't have GERD, so we use this as a non-GERD population screening test. And also, the last thing we're looking at is that perhaps we can add risk stratification biomarkers on the folks that do have Barrett's to assess who has dysplasia, to make the test more useful. So I've shown you now that we have real problems finding these cases and that we're not making much of a change. I'll show you some good news now, which is that if we find the cases, we do a pretty darn good job of making sure they don't die of cancer. And the reason for that is that we've had big developments in endoscopic eradication therapy, or EET. And I'll show you what this looks like. So if patients are detected to have Barrett's and have progressed to either low-grade, high-grade, or intramucosal cancer, all of our leading institutions now suggest that those patients should get endoscopic therapy for those problems. If they have non-dysplastic Barrett's, we don't suggest that they get it, and the reason is that progression, as I've already told you, is very low to cancer and non-dysplastic Barrett's, so we don't tend to treat those patients. How do we do it? First thing we do is go looking for nodular disease in the Barrett's, and here's a nice group of pictures from Ali Pesh where they found some nodular disease in Barrett's. They did a endoscopic mucosal resection, and this is what it looks like after they put a snare around it and removed it. This is a nice excision, and everything around it looks quite good. After we do that, we do endoscopic ablation. For those of you that are familiar with this, we used to do endoscopic ablation with photodynamic therapy. These were the bad old days. This didn't work very well. It was expensive. It really caused a lot of pain to the patients, and we don't do it anymore. You certainly can do endoscopic ablative therapy with argon plasma coagulation, but it's somewhat slow and the energy is not evenly distributed, so we don't do it very much except for very small portions of Barrett's esophagus. This is the workhorse right now in most Western endoscopy labs. This is radiofrequency ablation, and these are the various tools that we have available to us. They're all the same idea. It's essentially high radiofrequency waves that are spread in a normal distribution throughout the surface that allow us to deliver energy and cause a very fixed amount of depth of penetration of ablation. This is spray liquid nitrogen cryotherapy, which is available in some labs but not widely available. And then the newest kit on the block is balloon-based nitric oxide cryotherapy, and I'll show you a little bit of data on that. The short answer is that nobody knows for sure of all those treatment modalities that I just showed you which one is the best for dysplastic DE, or for that matter, dysplastic squamous epithelium, which we use quite frequently as well. The most extensively studied and the only modality with level 1 evidence of cancer prevention is actually radiofrequency ablation. And that's what this looks like. Here's the way it's done. This is a little cartoon. The balloon is put down in a deflated fashion. It's then expanded to touch the walls. It delivers energy to the area of the Barrett's. Then you remove the balloon. You go back down, and there's a dense coagulum where the radiofrequency ablation has occurred. You scrape all that coagulum off using a cap, you can see there. And then after you get it all clean and you lavage it, you go down for a second round, and again you place the balloon, and again you deliver the radiofrequency ablation. And you can do this in 20 or 30 minutes. This is not, what I've just shown you is not a particularly long or arduous process. And it works quite well. After you've done it the second time, you get kind of this brownish appearance of the epithelium. The second one that I showed you is liquid nitrogen spray cryotherapy. Here you see a decompression tube in the esophagus, and now we're spraying the liquid nitrogen onto the Barrett's, and you can see that you can hold the Barrett's in a very hard freeze, essentially like an ice cube. And this is pulling the gaseous nitrogen out as you provide this treatment. And we'll hold it in a hard freeze for 20 to 30 seconds, allow it to thaw, and then give a second round of this kind of treatment. And it works quite well as well. And then the last one I mentioned to you was this balloon-based liquid and nitrogen cryotherapy. This is what it looks like as it's delivering the nitrous oxide. And unlike the spray liquid nitrogen I just showed you, the nitrous oxide never touches the patient. It stays inside this balloon. And this is what this looks like. You actually, so here's a segment of Barrett's esophagus. We're going to position the cryo balloon in the segment of Barrett's. We're going to blow it up. We're going to look through this balloon. Now you see there's a little hole in the central stylet here, and it's going to shoot a little bit of gas up onto the balloon. You'll see it here in a second. See that right there? That's positioning the spray to hit this area of Barrett's that we want to kill. And now you'll see it being compressed for 8 seconds. After this 8 second of delivery, the balloon will be dropped and you'll see this ice patch. By the way, everything I'm showing you here that we're using in adenomatous disease will work in squamous disease as well, although there's not as much data because we just don't see as much in the West. And that's what it looks like. And here's a recent publication that we had looking at this. Mimi Canto is the first author of this. And what we did here is we had 11 centers. We enrolled 120 patients. We were able to get complete response for dysplasia in 76%, complete response for all intestinal metaplasia, meaning we got rid of all the Barrett's in 72%. We had some dropout because this was during COVID, so the per protocol numbers are 97% and 91%, quite a bit higher. One patient progressed despite these treatments to cancer, and overall it was pretty safe. There were 3 serious adverse events. This seems to hurt less than radiofrequency ablation. We rarely have to give narcotic analgesia, and we saw strictures in about 12% of patients. And this is what a case looks like after they're done. One thing that we know for sure is that after you've been treated with ablation, regardless of the type of ablation, the likelihood that you ever die of cancer is actually quite small. This is a study that we did a few years ago of 5,000 patients who were in the US RFA registry, asking the question, after they've been followed for several years, what's the likelihood of death from cancer? And you can see the various histologies of Barrett's on the left-hand side here. And the short answer is that out of almost 5,000 patients treated for non-malignant disease, we saw 3 deaths from esophageal adenocarcinoma in this group. Now, if you already had intramucosal or invasive cancer, the death rates were a little higher, but still there was a total of 5 of those. So the bottom line is that ablation appears to be quite protective against subsequent death from cancer. And ultimately, this is where I think we're headed. We're going to use one of those less invasive tests that I just discussed with you, perhaps the cytosponge. If it's negative, you're scot-free. You will not need any more testing. If it's positive, we're going to apply to that same sample a biomarker panel for progression risk. You're going to be stratified into either low risk, where you might just get another sponge 3 years from now, or high risk, where you'll go straight to ablation. And this will be much better than what we're doing now. And by the way, I think the same paradigm can be probably applied to squamous disease as well. So I'll end with some conclusions, and then I'm happy eventually to answer questions during the Q&A. The epidemiology of both Barrett's and esophageal adenocarcinoma is favorable. I get the haunting feeling that perhaps the trends we're seeing in the West will be recapitulated in your part of the world as well. Current screening and surveillance practices are limited by poor risk stratification. I've tried to show you that we don't find most of the patients who would benefit from early intervention. Therefore, self-congratulation for improved care in subjects who have known Barrett's is largely unwarranted. I've shown you that we have a lot of great techniques to keep people who have Barrett's from going on to cancer, but most patients never benefit from that. Therefore, doing what we've been doing but harder or more aggressively is unlikely to result in success. Having said that, relatively small changes in our current paradigm would result in incremental improvements. And one thing that particularly frustrates me in the United States and Europe is that patients will come in for, say, a surveillance exam, and we don't take enough biopsies, or we don't spend enough time looking around. That really is frustrating. And some of those patients go on to get cancer. However, embracing disruptive technology, and I've shown you a few today in the way of screening exams and that kind of thing, and new non-endoscopic care pathways is needed to improve our approach to preventing esophageal adenocarcinoma. I hope this isn't true. This was said by Stephen Sontag, who's an endoscopist from Chicago. But I do think that right now we do a lot of endoscopy in patients with Barrett's who don't benefit much from it, and some of them probably are just waiting around for us to die. And I look forward to the day that we can take a more logical and more interventional approach to these patients. Thank you for your time and your attention.
Thank you, Dr. Shaheen. That was wonderful talk. I think we really enjoyed. I think you need a break. Take a small break. I think we have the question answers as decided earlier after the end of the second talk. May I request Amit to invite?
Yeah. So thank you. First of all, thanks to Dr. KC for inviting me to moderate this session. After the talk on Barrett, we move on to GERD. So GERD, as you know, is a very common problem all over the world. Even in India, the prevalence is quite high, 7 to 10%. And it's seen not only by gastroenterologists, but across all specialty primary care and secondary care. So it's very important to have a proper approach to evaluation and diagnosis. And for this, we have Professor Shobna Bhatia, which Dr. KC already introduced her. We know Madam is a well-known expert in this field and she has done a lot of work. So let's hear from him about GERD, what are the recent advances.
Dr. Chandrasekhar, I think thank you for calling me to talk on this special session on GERD, and I will be adding some stuff on what Dr. Shaheen said about the epidemiology of GERD in India. This data needs to be really corrected, and I'll just start by sharing my screen now. Once again, thank you, Dr. Chandrasekhar, and thank you, Amit, for introducing me. So let's start with gastroesophageal reflux. And what I'm going to talk is a little bit about the epidemiology, diagnosis, and medical treatment. I will not talk about surgery or any other complications of GERD. Dr. Shaheen has covered Barrett's esophagus very well. So my job is to look at how we manage reflux in India with the recent changes that have occurred because of new technologies and new treatments. So first is how common are GERD symptoms and what are they? So the most common symptoms are heartburn and regurgitation. Dr. Shaheen did show a similar slide showing that India is one of the hotspots of gastroesophageal reflux, and this data has probably been picked up from one of the studies that was published from India. I'll show you a few more studies that we did, and that the reflux isn't all that bad in our country. Let me show you all this. So the first study we did was somewhere in the early 2000s, published it in 2011. This was a multi-centric study from almost more than 15 centers, looking at 3,000 patients. And symptoms more than once a week, which means we took at least twice daily symptoms of either heartburn or regurgitation, were present in 7.6% of subjects. These were healthy individuals, and GERD was ruled out prior to inclusion. Then there was a study from a high altitude area, which was a specific area in Ladakh. And this study was conducted by the people in All India Institute, and they found that the symptomatic reflux as defined by heartburn, any heartburn, was 18%, but 90% had mild disease. There was another study amongst employees. Now remember that employees in government hospitals are usually better off than the lower socioeconomic status of other people in the community. So this is not again a community study, but it gave us an impetus that heartburn on a weekly basis was present in 6% and on a daily basis was present in 3.6%. Again, it's not as high as the epidemiology in the world shows. This was one study where they looked at the GERD-Q questionnaire published from Kerala, and here they defined significant heartburn as occurring once a week. And here the prevalence of weekly symptoms was 22%. Then came a very lovely study from, again, South India, but this time it was a mixture of rural and urban subjects, 6,000. The risk factors were urban residents, older age, infrequent milk intake, and obesity. So the prevalence was only 8.2%. Subsequent to that, Dr. Uday Ghoshal did a meta-analysis on all the Indian studies and said that the random effect model, the proportional of GERD was 15%, with a 95% confidence interval of 11 to 20%. And as mentioned in most studies, obesity was a significant risk factor, smoking was a risk factor, as well as eating spicy food. So let me just make this correction that Indian GERD is 15% or less, but definitely not as high as it is projected in the rest of the world. Now, how do we diagnose GERD? Since we all depend on symptoms and all our studies are based on symptoms, most of the symptoms that we looked at are heartburn and regurgitation. We know that the symptom sensitivity and specificity is not as high as that of objective evidence. We also know that many patients who have only heartburn, isolated heartburn, quite often do not have true gastroesophageal reflux disease. So let's look at this two studies. One was published last year, but the original one I've displayed here. This is the Diamond study published from John Dent and his group, where they looked at patients with reflux and they conducted a reflux disease questionnaire. The patients were queried by family practitioners as well as gastroenterologists, and the patients were given twice a day PPIs. What is good about this study is it shows us that eventually the sensitivity of symptoms is about 70% and the specificity is also 70%, and response to the PPI is almost similar. This does mean that there is a large number of patients in whom the symptoms are not telling us whether this is true GERD or not. But however, it is better to give a PPI test rather than do other diagnostic testing when the patient comes to us for the first time. So now, what is the definition of GERD? Previously, we all know that we looked at GERD as reflux of gastric contents resulting in symptoms and or complications. We know how poor symptoms are, and the recent definition is that you have to have an actionable definition of GERD, which means there has to be evidence either of mucosal injury or of abnormal acid exposure, which is demonstrated on reflux monitoring study. This is important when you want to give the patients long-term PPIs or you want to subject the patients to any invasive techniques, either like an endoscopic procedure or surgery. And in these patients, we have to prove GERD before we do anything else. In the rest of the patients, it's quite okay to give them intermittent PPIs. So how do we manage our GERDs? Mostly we manage them given multiple guidelines that come every few years. And if we see this guideline from the American College Gastroenterology published 2 years ago, said that if there is heartburn regurgitation without alarm symptoms, and symptoms are of a sufficient frequency to impair quality of life, give them 8-week, once before meal, daily PPIs, and then we follow on from there. So we did a similar thing in 2019 as part of the Indian Society Gastroenterology Task Force, and we also said the same thing, except that we said that for initial management, if the symptoms were mild, the patients could try out either an on-demand H2 receptor antagonist or even antacids. And then if there was no significant response, we would go to PPI once daily. And if the patient still didn't respond, we would optimize the PPI before saying that this patient should undergo an upper GI endoscopy. So when would we do an endoscopy? We would do an immediate endoscopy if the patient had alarm symptoms, which meant weight loss, recent onset symptoms, first time symptoms in someone who is 60 or 70-year-old is not something that we like to see. But in someone who's young, has had a lot of spices, has had some stress, and gets symptoms occasionally, well, we don't need to investigate them. If there is evidence of anemia or there is dysphagia, dysphagia is always an alarm symptom, and in such a situation, we would do an immediate endoscopy. So when do we do endoscopy? Now, first is to establish the diagnosis of GERD. When do we do this? If the patient comes back with symptoms of GERD after an initial trial, either he fails the PPI or he is successfully treated by the PPI and gets recurrence of symptoms, these are patients when you want to establish the diagnosis of gastroesophageal reflux disease. So first is establish the diagnosis by looking at whether there is any form of esophagitis. Evaluate for complications, and we've had this lecture on Barrett's esophagus already. In patients who have grade C or D esophagitis, we want to assess the response as well. If the patient has not responded, we want to see what's happening because we want to rule out other disorders that present with heartburn. I'll come to those. And patients who are candidates for any form of intervention. So this is where we would do an endoscopy, and we would do it urgently if the patient had any alarm symptoms. So this is what the endoscopic pictures are. There are multiple pictures here. The one on the left, the first one, shows a hiatal hernia, but the mucosa is essentially normal. As you go down right, we see that there is a lot of mucosal damage, which can be called as grade C or D esophagitis, depending on the damage. Now, if this esophagitis is clearly evident on endoscopy, there is really no need for further investigations to start treatment. all investigations can actually stop here. And we will come to conditions when we will do further investigations. So the differential diagnosis here during endoscopy, we might see eosinophilic esophagitis, which also presents with heartburn, and occasionally with dysphagia. We might find esophagitis or some ulcers which may be due to some infection in patients with a short history of heartburn. It's important to know that when we do these endoscopies, they should be done after at least 2 to 3 weeks of discontinuing anti-acid drugs, which means acid suppressive agents. This is because if there was mild esophagitis that the patient had, that could have healed when the patient came to us, though the symptoms had not resolved. And we would unnecessarily label this patient either as non-erosive reflux disease or as someone who did not have reflux. So therefore, even when we want to do endoscopy, it has to be done without the patient being on any acid suppression. So sometimes if there is any damage that we see, like rings, we would do an esophageal biopsy. But if the endoscopy was normal, what would we do? And that is what we will come to after the first phase of treatment. So what are the aims of therapy? The aims of therapy are relief of symptoms, healing of esophagitis, and prevention of complications. So once we found esophagitis, this is what we will do. So initially, there's always a lifestyle modification, asking the patient to stop spices, avoid late night meals. Whether these are evidence-based or just from clinical experience is something that we still haven't figured out. But some patients do feel better by stopping smoking or avoiding large evening meals or even lying down with the head end of the bed elevated. Weight reduction is something that has been found to have significant effect on gastroesophageal reflux. So what is the next treatment? The next treatment is medications. I brought out this slide from 1997 because this was the initial studies which showed us that PPIs were actually the best drugs. Of course, we changed our opinion a few years ago, but at that time, they were the best ones available. And heartburn relief in patients with grade 2 to 4 esophagitis, LA grade B to D is what I presume it is called now. Total heartburn relief was seen in approximately 80% of subjects, whereas H2 receptor blockers was only 47%. So symptom relief was best with the PPIs. Now PPIs, irrespective of dose or duration, provided good overall symptom relief, except that there were certain caveats. And when there was mucosal healing, placebo of course had very low mucosal healing, but if you took the PPIs, it was almost 80% as compared to H2RAs. And in those days, we also used prokinetics alone for looking at whether patients would heal their esophagitis. Efficacy of PPIs for as far as equivalence is concerned, there was this very elegant study conducted by Dr. David Graham. Of course, he was looking at in vitro evidence of acid blockade and found that the strongest PPI were actually esomeprazole and rabeprazole with their ability to suppress gastric acid. But in clinical life, this did not really pan out, and we know that most patients, irrespective of the type of PPI, respond well. In patients with grade D esophagitis, we would start esomeprazole or rabeprazole, but in others, there was no difference between the PPIs. So whether we give once a day or twice a day, what is the benefit? So if the patient doesn't respond once a day, we jump to twice a day PPIs. And here, this is a study published a few years ago with looking at the 7 RCTs that were published, and we found that esophageal healing was at 4 weeks versus 8 weeks, there was a 50% difference. But the symptom relief was not very significantly different in patients after a double dose PPI. So what is happening? When the esophagitis heals and the heartburn still continues, what is happening. So esophagitis healing, we know, is in patients who have esophagitis. 80% will heal their esophagitis as compared to placebo, and the number needed to treat is less than 2, which means PPIs are very good. But when it comes to heartburn relief, whether there is esophagitis or not, 56% of patients only have heartburn relief. And if there is no esophagitis, that means what we now know as patients with non-erosive reflux disease, then the heartburn relief is only 40%. As far as regurgitation is concerned, the relief is only 45%, less than 50%. So therefore, symptoms are different and esophagitis is different. So there's something more going on here, and we'll come to that. So what are the causes of non-response? The first is poor compliance. We know that PPIs have to be taken on an empty stomach, except I think dexlansoprazole, which has the advantage that you need not take it before a meal. There may be residual gastroesophageal reflux, probably because some of the proton pumps keep getting activated and the patient has that much of sensitivity that he feels that reflux and therefore symptoms persist. There may be other comorbidities like systemic sclerosis, or there may be drugs which the patient is taking like bronchodilators or cardiac drugs which are also causing decrease in LES pressure. There may be genotype differences in which some of the drugs which are metabolized by the CYP2C9 in the liver and the patient is not responding to them. There may be a wrong diagnosis, and I showed you that EOE can present like GERD, and the patients will definitely not respond completely if there is another disorder. And of course, there is reflux hypersensitivity as well as functional heartburn, which I will talk about. So now, what is the approach? My first question is there reflux? If there is reflux, are the symptoms due to reflux? Or if there is no reflux, significant reflux, are the symptoms due to reflux? Why are symptoms present even after acid control? And what should I do if there is reflux present or reflux absent? So we'll look at a few things. These are the multiple tests that are available for diagnosis of gastroesophageal reflux disease. We've already looked at endoscopy. We'll look at the other ones now. Now, first is esophageal manometry, and it does not diagnose gastroesophageal reflux disease. So, first is a statement that reflux disease cannot be diagnosed by esophageal manometry. We do it for two reasons. One is because we want to place the pH metry catheter 5 centimeters above the manometrically defined lower esophageal sphincter. And we want to rule out other disorders before we go in and do a surgery for suspected gastroesophageal reflux disease. So what are the things? We look at the lower esophageal sphincter pressure. We will check for a hiatal hernia, check for esophageal motility and a contractile response. So this is a cartoon. On the left, we see a normal esophageal manometry. This is the upper sphincter. This is the lower sphincter. And this is the peristalsis that occurs after a swallow. On the other side, on the right, you see that there is absolutely no peristalsis. The lower esophageal sphincter is not opening after a swallow as it is here. So this is a patient with achalasia. And quite often, patients with achalasia can present with regurgitation and occasional heartburn and give an impression of reflux disease, and this is where manometry helps. The other place that manometry helps, this is a normal esophageal manometry, just had to show it, is when you want to see and you see that there is an esophageal outflow obstruction, which means that the LES pressure is high. And this patient actually may have borderline dysphagia, which he may not have recognized And these are people again who should not undergo surgery. Of course, there are patients who think that they have reflux and they actually have either rumination or supragastric belching. And you see on these manometries that there is a rumination episode where there is rise in the intragastric pressure followed by retrograde flow of the gastric contents. Here there is no prograde flow as we saw in peristalsis. There is a retrograde flow, and this patient, and after that there is an upper esophageal sphincter relaxation, and then the patient may actually swallow his food again. This is an obvious supragastric belch where there is contraction of the esophageal junction, and then there is negative intrathoracic pressure. And here the patient actually sucks in the air, or he may throw out the air. So therefore there is retrograde movement and expulsion of air, which is suggestive of a supragastric belch, and these patients should actually be given neuromodulators and behavioral therapy. The other thing is, this is of course rumination, and there is sometimes a transient lower esophageal sphincter relaxation with inhibition of the crural diaphragm, which may or may not be associated with gastroesophageal reflux. Another thing that is recently been recognized is that while doing manometry, you can also elevate the leg and check whether the lower esophageal sphincter is actually competent or not. And here you see that the lower esophageal sphincter contracts during leg raising and increasing the abdominal pressure, whereas in the second cartoon here on the right, you see that the LES does not increase its contraction, and you can see a flow of fluid coming back into the esophagus, suggesting that this LES is incompetent, and if the esophageal pressure rises by more than 11 millimeters of mercury, it is suggested that this patient may have reflux. The other thing that can be done during manometry is to check whether the peristalsis whether the esophagus has good reserve or not. Quite often, the esophageal peristalsis is weak, and what we do is we give a multiple rapid swallow. So when you give multiple rapid swallows, the peristalsis actually becomes a little more prominent, or you find that the DCI increases, and in this case, it is expected that if there is good reserve, then the patient will not have any postoperative symptoms after a fundoplication. But if there is poor motility, there is a chance, which is not still confirmed, that the patient may have dysphagia. So manometry in GERD is done to rule out other disorders like rumination, belching, achalasia, which are contraindications for fundoplication, and you want to establish the relative contraindications for a full niscence in patients who have an insufficient peristaltic reserve. Now, once manometry is done, for the usual reason, that is to place the pH catheter, we come to pH metry. Now, pH metry is measurement of pH in the esophagus, which is the catheter type, and the Bravo, which measures only acid. And when you need to measure non-acid reflux, it is impedance. So this is the catheter-based pH metry, where the pH less than 4 is recorded. Wireless pH monitoring, which is placement of a capsule endoscopically, is done only when patients are intolerant to nasal probes, though in many countries, wireless pH monitoring has become the norm. So this is the wireless pH capsule, which has been attached with a clip to the esophagus, and it stays there for up to 96 hours. So what do we measure in this? We measure how much is the acid exposure. So therefore, normal values which were previously looked at have been changed slightly. If the patient has normal or less than 2 heartburn episodes per month, then the usual acid exposure time that we get is between 3.9 to 7%. And therefore, in the Porto consensus, which was done in 2017, it was decided that the acid exposure time of less than 4% is normal and less than 6% is likely to be normal. And patients who have erosive esophagitis have an acid exposure time of usually more than 9%, but more than 6% is now taken as the cutoff for defining gastroesophageal reflux. Now, you could do only a nasal pH metry, which usually has a life of only 24 hours. After that, the catheter stops working. So, in order to diagnose patients who have intermittent reflux, we do a Bravo pH metry. Otherwise, we need to do an impedance pH metry if the patient has non-acid reflux, or if the patient is on PPI. Then in that case, we want to see whether the patient still has weakly acid reflux. So this is the impedance pH monitoring. Impedance tells us about the flow of substances across the esophagus. In most catheters, we have two pH channels where one lies above the LES 5 centimeters and the other one is in the stomach, and 6 to 7 impedance channels. The impedance channels are mostly placed in the lower esophagus and in the upper esophagus. This is what the final 24-hour graph looks like. Most softwares will have a similar tracing. The top tracings are all impedance, and there are two tracings for pH. One is the gastric pH and one is the esophageal pH. So now we have to look at this by expanding the study and looking at each of the reflux episodes that the computer marks. So now we see here that there is this retrograde flow of substances which is recognized by a drop in the impedance here. And we also see that the esophageal pH has dropped, and at this point the esophageal pH is 3.2, which means that this is a reflux episode. On the other hand, if a patient is on PPI, you might notice that this reflux episode has occurred, but the pH in the esophagus at that point is 5.2, which means this becomes either a weakly acid or a non-acid reflux episode. And this is important to recognize because in patients who are not responding to PPIs, some of their symptoms may be due to non-acid reflux. So how do we approach these patients? So if a patient has typical symptoms and an empirical trial of anti-secretory therapy works, and there are no alarm symptoms, we end at empirical trial. We do esophageal evaluation only if the patient has not responded. So when there is evidence of GERD, let's say during the first endoscopy, we found that the patient had esophagitis or Barrett's esophagus. Then in that case, we want to find out why symptoms persist, and we test on anti-secretory therapy. And here we cannot use the capsule, we need to use a catheter-based pH impedance to find out if the patient has reflux on therapy. However, if the patient then came to us, did not have any reflux on endoscopy, then we want to find out if there is reflux. We test off anti-secretory therapy, where we could use either a wireless pH monitoring or catheter-based monitoring. And evidence for or against conclusive GERD is what the Lyon consensus states, which I will come to. So now let us look at this. A little complicated diagram, but easy to understand. So if we have a patient where there was no GERD initially, and we did the esophageal function testing of PPI. I said that the acid exposure time should be more than 6%. Now, reflux episodes that we measure, if they are more than 80 per day, we are sure that this is gastroesophageal reflux, irrespective of what the whether there was esophagitis or not. If it is in between, we say that this is still possible, but we're not sure. On the other hand, if the acid exposure time is less than 4% and the number of episodes is less than 40, and there is negative symptom association, then in that case we say that this patient has functional heartburn. Occasionally it may happen that the patient may have a symptom, and at that point in time there is a reflux episode. Even though the total number of episodes is less than 4%, we say that this is a symptom association probability, and in these cases we say that this is reflux hypersensitivity. So reflux hypersensitivity, NERD and GERD need to be treated by optimization of PPI. On the other hand, if patient is already on PPI, continues to have symptoms, and we have similar pictures, if the acid exposure is still 4%, then in that case we say that this patient requires increase in the drugs. And if the patient has only LA grade A but still has total reflux episodes which are high, we say that this patient also needs optimization. In the other two, we say that these patients have either a functional heartburn or a reflex hypersensitivity. I'm sorry for this mistake. Reflux hypersensitivity overlap, and they require additional treatment. So we looked at how these things have evolved. 1999 and 2006, we banked on symptoms. When Los Angeles grading was done, it was based on endoscopy. And it took more than 20 years to come to say that pH impedance needed to be done, and their guidelines were made, and then the Chicago classification for manometry came up. So steps for optimization of PPI treatment. We should make sure that the lifestyle modification is done to improve compliance and ensure proper dosing. Split the PPI throughout 24 hours rather than giving double dose PPI at one time. Switch to another PPI, maybe add anti-reflux medications like a RAFT preparation, baclofen, or a prokinetic, and of course address psychological comorbidity. Now, in the last few years, we also have additional drugs which are the PCABs. So way back in 2015, this is a Japanese study, they showed that vonoprazan was better than esomeprazole and rabeprazole in terms of acid suppression for 24 hours, and even on the day one it suppressed acid significantly. So it was definitely better, and now that it's available in India, we have access to this. These are the major differences between PPIs and PCABs, where
Excuse me, Dr. You have 2 more minutes.
How much time do I have?
2 more minutes.
Okay, I'll wind up here. Yeah. So we have to find out the differences, but we know that PCABs are safer and more efficacious, and this is a slide that I have to show in patients who do not respond to PPIs, or directly in severe esophagitis, we can directly start PCABs, and this is a study published this year which shows that in the network meta-analysis, PCABs were much better and much safer as compared to all the PPIs. So I'll have to skip this and I'll stop here, Dr. TSV. What I will just show is the last slide. Okay. So in severe GERD, we step down, we start with PPI, reduce to maintenance treatment, and if patient presents with any complication, we do an endoscopy at follow-up. And I'll stop here. Thank you.
Thank you, ma'am, for the wonderful presentation. Really clear and very informative. I think we'll move on to the Q&A session.
Yeah, now the schedule is like that. The first question, thank you, Sobna and Professor Nicholas, for the wonderful presentation. I will start the discussion with the Sandeep asking the question. So Professor Nicholas, you have any comment and question? So we'll go like that. First moderator, second moderator, then panelists. So then we go around 3-4 times.
Okay.
We have a 30 minutes now. Last 5 minutes, leave it for the chit-chat session. Okay. Starting with the Sandeep.
Yeah.
So you were turning question to
Dr. Shaheen, you're there. We can't see you. If you can come back on the screen.
Professor Nicholas.
Yes, I can hear you. Can you hear me? I'm
Yeah.
trying to make my video work.
Okay. Thanks for being there. It's still late, I know. What do you suggest after the treatment of Barrett's? Do we still continue the PPIs even if the mucosa has come back to normal, because these patients are probably predisposed to GERD?
Yeah, it's a terrific question, and the answer is that we know that even with ongoing therapy with PPIs, that the recurrence rate of recurrent Barrett's after successful ablation is about 8% per patient year. So the implication is that after successful ablation, these patients should be maintained lifelong on PPI therapy. Now, whether that PPI therapy needs to be BID therapy or perhaps once daily therapy is sufficient depends on the patient. We know that approximately 1 in 3 patients with Barrett's esophagus will still have pathologic reflux exposures despite once daily PPI. So as Dr. Bhatia was telling us, there is some difference between PPIs, but in general, you can expect about 1 in 3 of your patients to require twice daily PPI to remain reflux free.
Thank you.
Thank you, Professor Nicholas and Sandeep. Before Amit asks question to Dr. There is a question from the audience. Which is your preference now? The PCABs are available. You see a case of Barrett's esophagus. You prefer PPA or PCAB? Or is any study available there? Professor Nicholas.
If you'd like me to answer that, I'm happy. Yeah, we're actually currently doing some studies to answer this question. For now, what I can, so we have no direct head-to-head comparison in the Barrett's population. Having said that, what I can tell you is that for the vast majority of patients, twice daily PPI in the Barrett's population is quite good at normalizing pH. And at least in the U.S., the cost of the PCABs and the difficulty obtaining PCABs for our patients mean that we tend to use the PPIs. Whether with time and when those costs come down, if we perhaps will change our thinking on this, is yet to be determined.
Thank you.
Yeah, but FDA has allowed approved PCABs for the erosive esophagitis severe and H. pylori therapy only. I don't know about the recommendation.
Well, and there is
Also for
there's a approval for non-erosive disease as well. But the problem we have is that because they're quite more expensive in the States, our insurers are all requiring that you fail PPI therapy before you're allowed to give them.
Thank you. Dr. Amit to Sobna.
Yes, ma'am. So nice presentation. So one of the things we know
Thank
that GERD is can be chronic in many patients actually. So the question comes about the duration of therapy. So if somebody like has a grade C or D, which is a very small proportion, we say long-term therapy. So the question is like this long-term, does it mean indefinite daily for years, months, or this thing? And in these patients, do you repeat an endoscopy to see if things have healed after some time? So what's your practice now?
So in the first instance, thank you, Amit. So in the first instance, if a patient has grade C or D esophagitis, you start with a twice daily PPI, or now that vonoprazan is available, you can start with the PCABs directly. So as Dr. Shaheen was saying, that the cost of PCABs is prohibitive in the US, but in India, I think we still have an edge that cost is not that prohibitive. So some patients can afford it. So grade C esophagitis, grade D esophagitis, I would start with vonoprazan and then watch. And in these patients, after say 8 to 10 weeks, I I would like to do an endoscopy to see if there is healing. Because at 4 weeks, there is no point. Healing would not have occurred. You can even go up to 12 weeks. And if the patient has healed esophagitis, then you monitor the symptoms. But these are patients who will require long-term therapy. Now, if you stop the PPI or the vonoprazan in these patients, at the end of 1 year, almost 90% will have a relapse in symptoms as well as esophagitis. I don't think they even wait for 1 year. Within a week or 2 weeks, they are unable to discontinue the drug. So we have to continue it lifelong. For grade A, I think we give them on-demand treatment, and I think the FDA has already approved it for NERD as well. So we can use vonoprazan, but I would prefer milder acid suppression in these patients. For grade B also, I would step down from vonoprazan, or if I was giving a PPI twice a day, I might come to once a day. But the main thing is symptom control.
Okay.
No, that's very important. For the mild the PPI stewardship is very important.
Before Dr. S.C. Mitra asks question to Dr.
I was just saying so that because GRD is common and PPI stewardship is also very important. For mild disease, we should not be using too much PPI, indefinite PPI. That's something very important for the
Absolutely. So
I agree with you. And Dr. S.C. Mitra?
Yes. Nicholas, what was the gold standard for the sponge test?
Endoscopy with biopsies and the finding of at least 1 centimeter of columnar epithelium in the esophagus. So they use kind of traditional definition of Barrett's esophagus.
All these patients underwent both the tests, the sponge test as well as endoscopy.
That's correct. For both of the two things I showed you, the balloon as well as the sponge, they both underwent subsequent endoscopy.
Thank you.
You have a question to Sobna, S.C. Mitra?
No?
I think you are very clear. You are part of
Thank you. Okay, let me ask Dr. Shaheen.
Sandeep?
Yeah, so what happens to patients who have Barrett's and large hiatus when they undergo surgery for hiatus? Do we have to remove the Barrett's first or at the time of surgery, or do they have ablation first and then Barrett's, then a hiatus surgery? How should that be approached?
Yeah, that's a terrific question, and this is something that we struggled with in the early days of ablation. We said, my gosh, what if we do a fundoplication and then the patient progresses to need an esophagectomy and we've just done a fundoplication? This is a terrible situation. The patient will have scar tissue and will be a very difficult esophagectomy. Now, the last 20 years have given us guidance. What we know is that the rate of success of ablative therapies in Barrett's esophagus is so high that even in the setting of a patient who has dysplastic Barrett's esophagus, if you need to perform fundoplication to get adequate control of reflux, it's fine to perform that fundoplication first and then to perform the ablation subsequent to the fundoplication, and it's vanishingly rare that that patient will progress to need esophagectomy. So we can now give clear guidance to our surgical colleagues that, oh gosh, this patient has dysplastic Barrett's, I don't want to do a Nissen and then do the surgery. You can say to them with some confidence, don't worry about it. Go ahead and do the fundoplication. That will help me because it will control the acid while I do the ablation.
Okay. Dr. Vikas, thank you, Dr. Nicholas. Vikas, you have a question to Dr. Nicholas. Vikas,
I have a question for Professor Shaheen. It's regarding diagnosis of Barrett. So when we are doing endoscopy and we are suspecting Barrett, is it mandatory to take a biopsy for confirmation of Barrett? And secondly, when we do a surveillance, do you do an image endoscopy or you take a multiple biopsies according to Seattle protocol for screening of dysplasia in these patients?
So, great questions. The first thing that I'll say is I was very impressed by Dr. Bach's data showing that perhaps the rate of reflux was a little bit lower in India than at least some Western writers have suggested. Although I will also say that the meta-analysis says 15%, which is still quite substantial, a high number of reflux, really. With respect to when you're doing the screening and the surveillance biopsies, my suggestions would be as follows. You can't form a complete diagnosis of Barrett's without systematic endoscopic biopsies, okay? We recommend at least 6 biopsies in anyone who demonstrates at least a centimeter of columnar tissue in the esophagus. So if you see what appears to be columnar tissue in the tubular esophagus, we suggest at least 6 biopsies at that time of the screening endoscopy. And if the patient does not demonstrate why 6? Because less than that provides the chance for a sampling artifact and you miss the goblet cells. If those 6 biopsies do not demonstrate intestinal metaplasia, that patient should not be diagnosed with Barrett's and should not be enrolled in a surveillance program. There are a substantial number of patients who have some columnar epithelium in the Barrett's, usually short in the esophagus, usually short segment, that do not demonstrate intestinal metaplasia. These patients have not been shown to be at increased risk for esophageal cancer and do not require surveillance. Amongst the patients who do show that, they should be enrolled in a surveillance program, and at every single endoscopy, these endoscopies are to be done at 3 to 5 year intervals, they should have systematic 4-quadrant biopsy sampling of the affected areas. And what you're looking for there is the distribution of the intestinal metaplasia and the presence of any dysplasia.
Okay, thank you. Okay. Thank you, Dr. Nicholas. Dr. Barnabas, you have a question to ask. Dr. Barnabas.
Yes, I am audible.
Yes, you're audible.
Yes, regarding the role of non-steroidal anti-inflammatory drugs and statins, whether they are useful in preventing the development of Barrett's dysplasia, 1. And the second question is, cardiac type of epithelial cells in the esophagus is also taken into consideration for Barrett's. And what is the definition of ultra short segment Barrett's, short segment Barrett's, and long segment Barrett's?
I think the whole session you have taken over, Barnabas. Thank you. Nicholas, you will go and answer very short.
And another question also I got.
No, only one question, everybody. I know that you have a lot.
Okay.
So statin and non-steroidal.
I hope I will remember all this, Dr. Barnabas. I apologize if I forget.
So tell me your question.
So the first one. The first one was the NSAIDs and the statins. The epidemiologic data very convincingly suggests that patients that are on NSAIDs or statins have a lower risk of progression to esophageal adenocarcinoma than those who are not. One problem we have with these data is that they're epidemiologic studies, and we don't know where those agents interfere with the progression to cancer. Whether it stops you from getting Barrett's in the first place, or whether in the subgroup with Barrett's, it stops the Barrett's from progressing. For that reason, it's difficult for us to make recommendations to say, put all patients with Barrett's on a statin, because if the effect is earlier, we will get no benefit from putting them on a statin. So right now, in most recommending societies, do not give firm recommendations for either NSAID prophylaxis or for statin prophylaxis in the setting of Barrett's for that reason. And of course, we're also worried that, at least in the case of NSAIDs, that we may actually get some negative effects since these patients already have high acid levels, perhaps will promote ulceration. With respect to, I'm sorry, go ahead.
Yeah, I think we have another question. If from Dr. Venkatakrishnan. He's been waiting. Dr. LD, what is your question?
Good evening. My question is to Dr. Shobna, madam. Madam, is there really a use of prokinetics in GERD in 2024? And what will be the... Yes, ma'am.
Yes. So, Dr. Venkatakrishnan, thank you for the question. So, I did not intentionally bring up prokinetics because most guidelines do not say that prokinetics should be given in all patients with GERD. Now, there is a small segment of patients with GERD who also have delayed gastric emptying. These are not dyspepsia. They have bloat and or they have repeated vomiting. Now, these are patients who will benefit by having an increase in gastric emptying. Secondly, there are groups of patients who have very low LES pressure or a hiatal hernia. They have significant volume reflux. When they have this volume reflux can be controlled with prokinetic, but it can also be controlled by telling the patient to have small frequent meals and not to lie down immediately after a meal. So prokinetics can be used, but most of the prokinetics that are there are only working on the stomach. The original prokinetics like betanicol, which we no longer use today because of its side effect, had some evidence to show that it worked on esophageal peristalsis. Mosapride has some effect on esophageal peristalsis. The rest of them work only on the stomach.
So, while you are answering this question, I don't see anyone best, Professor Nicola, the person, the usage of prokinetics in your, what is your opinion about? We don't see in US or the Western country using prokinetics in the management of GERD. What is your take?
I think Dr. Vats is spot on. I think that it's really come out of favor with the exception of perhaps a very selected cases where you also know that you have gastroparesis. Two issues. Number one, they're just not very effective, unfortunately. And number two, the ones that do show efficacy, many of them have been taken off the market or rarely used because of side effects. For instance, Cisapride was somewhat effective for GERD, but is now off the U.S. market. Betanicol is still available, but is limited by side effects. Prucalopride actually does work for GERD, but it's very difficult to get in the U.S. for that indication. We're much more likely to be able to get it for a lower GI indication. Because the combined effect of having poorly effective drugs and also drugs that have bad side effect profile have really limited the use of prokinetics in GERD.
I think I come to think of that the proper indication to use the prokinetics if you have a gastroparesis and the LES pressure is on the little low, so that you want to use the prokinetics. But most of the prokinetics is not available in USA. Itopride or Cisapride or so on. So how do you manage such cases? With the domperidone, metoclopramide, and they not as effective as the Itopride. So what is your take, Professor Nicholas?
Yeah, we'll use a combination of the agents you just mentioned, metoclopramide, erythromycin, domperidone can be gotten either through compounding pharmacies or by mail order from Canada. Occasionally, if the patient's got very poor gastric emptying, they may become a candidate for a GPOM if they've got paradoxical spasm of their pylorus. So we might try to do that to improve gastric emptying as well. There are some situations where we will try to make these efforts to see if we can improve GERD in that way. But I have to admit they're only very modestly successful.
One burning question from one of the delegates is, sometimes you see islands of mucosa above the line. Do you take it as Barrett's or you take biopsy or leave it like that?
Yeah, that's a good question. I think if they're very small trivial amounts within a centimeter of the Z line, I would just tend to leave those alone, because I think even if they showed intestinal metaplasia, I would be very hesitant to condemn that patient to a lifelong surveillance protocol. On the other hand, if they're greater than a centimeter in diameter or more than a centimeter from the Z line, even if they are discontinuous with the Z line, we know that the risk of progression in Barrett's is proportionate in part to the amount of Barrett's you have. So if they do have a more significant amount of their mucosa involved in possible Barrett's esophagus, I will indeed biopsy that patient, and I will retain that patient in the surveillance protocol. So greater than a centimeter in diameter, more than a centimeter in extent from the Z line equals yes. Less than a centimeter in diameter and small amount equals no.
So the size matters here.
Yeah.
And now another important question is, from the audience is, do Barrett's esophagus reverse with the anti-reflux or the hiatus endocarditis or aggressive PPA therapy?
So the question is whether or not it actually regresses with effective acid therapy. Yeah. So clearly, medical therapy does not cause reliable regression of Barrett's esophagus. There have been some, the best we can do is hope that it doesn't extend. There have been some papers that suggest that perhaps surgical therapy may cause regression in short segment Barrett's esophagus. I think this is unlikely to be true, to be honest with you. I think that there's just a change in the conformation of the hiatus. When you reduce the hiatal hernia, perhaps it's not as evident that there's a short segment of Barrett's involved. So I don't know that it's actually regressing as much as it's hidden from the endoscopist, or at least not as easily detectable. I think as a general premise, everyone listening to this should assume that Barrett's never goes away unless you perform ablative therapy on it.
Okay, last 5 minutes. Go to for chit-chat session, 1 minute. So this is just in the rapid fire, Nicholas. And what is a non-medical book you have read recently?
A non-medical book I've just finished 2 days ago was a book called Ishmael. It's essentially a philosophical book about how humans are destroying the planet for all of the other species on Earth. I highly recommend it. It was very enjoyable, made me think about how we handle pollution and that kind of thing.
So how do you find time to read that book?
You know, I'm an expert on one very small area, and there's maybe 4 or 5 important papers per year written. I have nothing but time. I'm going to go play golf after this. So.
Okay, right. Which is a famous quotation which you really, you get inspired, which you would like to share with us?
Oh, that's an interesting question. There's a quote from Winston Churchill that says that man often stumbles over the truth, but most times he dusts himself off and runs off like nothing happened. And I do think that we don't pay attention enough to the things that are obvious in front of our eyes because we buy into standard dictum. And one of the things about Barry Marshall is that he challenged the dogma of the day, and they gave him a very hard time about it until they realized he was right.
Yeah. May I ask the same question to Barry Marshall? What is the famous quotation? He says, science is not a democracy. So if you believe it and others don't believe it, doesn't matter. It's not a democracy. Yes, Sandeep, you want to ask what is the...
Nicholas, you said that Barrett's patients who are treated with ablative therapy don't die of the esophagus. What about patients with Barrett's who are not treated by anything? What do they die of? They have obesity as a cause, and they are predisposed to heart disease and lung disease and so on other things. So they have heart attacks or PA esophagus?
Yeah, the short answer is that the intent of your question is spot on. Many of them die of other comorbidities, stroke, heart disease, non-esophageal cancer. So the competing mortality is quite high in this group because of their risk factors. They smoke, they drink, they're overweight. So it does beg the question of how much we're really helping them if we avert their esophageal cancer, but they die 6 months later from their stroke.
Okay, Chandru, I have got a question to Sobna. Sobna, I have got
Dr.
Sandeep, either way you die.
Order. We will just confine to the lighter question now. We have 3 more minutes to go. Who is your hero in life, Nicholas?
My father just passed away, and he was one of my heroes in life.
Who is your favorite sports personality?
I'd say that one of my favorite sports personalities is Wayne Gretzky, an American hockey player who I suspect is not all that popular in India, if I had to guess.
Who is your favorite film personality?
I'm sorry? Say again?
Who is your favorite personality? Cinema, movie, or film, whatever you call it.
That's a terrific question. There are a number of actors here in the States that I'm quite partial to. I think that Tom Cruise is quite good. I enjoy his movies, and there's several others.
Tom Cruise, we have seen a lot of international faculty from USA, and unanimously they select Tom. What is mantra in one word? Mantra for work-life balance.
2 words: lean in. People are always so guarded about getting involved in things. Some of my best experiences in life have been because I got involved in an oddball project that turned out to be good. Ablative therapy in Barrett's happened because a random man walked up to me at a national meeting and said, "Hey, I figured out how to get rid of Barrett's. Come to my hotel room." And I was a little worried about that, but it worked out.
Okay, we have 1.5 minutes more. I will ask Dr. Sobna, what is your favorite non-medical book? 1 word answer.
Jonathan Livingston Seagull.
Okay, who is
I
your
don't know if
favorite
any of you have read it.
hero in life?
Favorite hero? I would say, who should I say? Maybe Amitabh Bachchan.
You don't even think about it. And what is your favorite quotation? Nicholas did not even think of the rapid fire. So what is your favorite quotation?
I beg your pardon? Sorry, I didn't get that.
Famous quotation which inspires you daily, or you like to share with us? Quotation or
So one of the best quotations that I have, and I have followed it for many years, is a story on how to think. So this is about a school child who was given 0 marks for a question.
We have 1 minute only. Okay.
So the quotation is that don't follow the norm. Always think out of the box.
Take a half day.
There's a lot more to it.
Okay, Sandeep, what is your famous quotation?
Don't worry, be happy. Don't worry.
Thank you. You are like a politician. Who is your favorite hero, Sandeep?
Favorite actor?
Hero in your life.
Actor or actress?
Amitabh Bachchan.
Oh, actor. Okay. And who is your favorite sports personality?
Sachin.
Sachin is your favorite. What is your mantra for work-life balance? 1 word.
Enjoy what you do.
Enjoy what you do, that you are able to balance the life and other things. Okay. Amit, what is your favorite quotation? Professor Nicholas is watching competitively. Who is actually better than?
I would say time and chance for no man. Time just moves on before.
Time moves on. Who is your hero in life?
I like Devanand. I like Devanand.
No, hero in life.
How do you Devanand say?
The one who really transformed you to what is the current state.
Okay.
That is what hero. Who
So
is
you
your
like
hero? difficult to say. Okay. And what is your, and which is the non-medical book you have read? I think Nicholas has scored over all of them, I think. Who is the non-medical? Dr. Barnaba, who is the non-medical? What is the non-medical book you have read?
I don't read any non-medical books. I always read only medical books.
Okay, who is the hero in life?
Heroine.
No, hero.
Heroine is Shivaji Ganesan.
Okay, I think you are of that age group, so I think I agree with you. What is LVK? Who is your hero in life? LVK?
He's mute.
He's frozen. Okay, now ladies and gentlemen, we are coming to the end of the session.
I listened to Roger Federer's speech after retiring from tennis. So Roger Federer recently gave a speech to a sports school in USA after he retired, and how he said that even though he won 24 Grand Slam titles, his percentage of shots which won was only 51%. That's how he says he translates that to the whole into his life. Life is like that. It's not that you always.
Yeah, I think it recently came in the news that. Oh, that is great. Actually, that thing. Because what is your favorite quotation?
But take it easy.
Take it easy. You are doing an interventional gastroenterology. It's a very serious job, and that is the mantra of our take it easy. Okay, right. Who is your favorite film personality?
Amitabh Bachchan.
Okay, now I come to the point. Those from West always say Tom Cruise. Those from India, they say Amitabh Bachchan. So we'll remove these questions. The next webinar onwards, Professor Nicholas, Sobana, and Sandeep, and Amit, and our great panel is Mr. Where is he? He's the one I was asking. Okay, and S. Mishra, he's busy. And Vikas and Barnabas and LVK, we had a fantastic time, and we really updated what is GRD and various issues related to the GERD and Barrett esophagus. I think we start looking into more and more about Barrett's in India. We'll come with the latest multi-center study. So we just will help Professor Nicholas will design the study in India, so that you can help us, you can be part of our group also, and we are planning to do a multi-center study. And why are we missing our Barrett's, or are we not applying our these diagnostic modalities properly, or we have any genetic influence or genetic kind of thing which is really prevents us from developing. That is a good area to investigate. With these viewers, ladies and gentlemen, thank you very much for this wonderful webinar. I sincerely that whatever we learned it will pass on to the benefit to the. Thank you very much.